Hello, yes, my name is Irving Taylor. I'm President of the European Society of Surgical Oncology, and we've actually just had our meeting in The Hague just last week. And really I would like to emphasise very much what has been said, the importance of the multidisciplinary approach. I don't think any surgeon now dealing with a solid malignancy would try and deal with this in isolation. I think we recognise the importance of a multidisciplinary approach. Indeed, I sit in awe and listening to these huge advances and developments really in both medical oncology and indeed in radiotherapy, which have had huge benefits in the management of our patients. But while it's just fresh in my mind from our meeting last week in The Hague, there were three issues as far as surgical management, generic issues, which came through very strongly, and I think it's very, very important perhaps for me to reiterate here. The first, this is in addition to the importance of multidisciplinary meetings, of course, but the first issue, which I think is absolutely crucial, is quality assurance. And we recognise, and indeed I think the whole surgical community recognises how important it is to ensure that the quality of surgery initially is appropriate. I think it has been shown that poor surgery cannot be compensated for by giving radiotherapy or drugs. The surgery, the primary surgery itself, must be of a high quality. And I'm pleased to say that through the European Cancer Organisation, through ECHO, there will be great support for a number of very important projects on quality assurance in surgery and other aspects. So we recognise that. The second major issue which is coming through really very, very strong, we've heard it for breast, we've heard it for head and neck, and we've heard it for lung, and that is this concept of neoadjuvant therapy, which basically is downstaging or downsizing of a tumour which may have been thought initially to be inoperable but can be converted to operability to enable a surgeon to resect a tumour which may not have been resectable prior to this. This is certainly in patients with liver metastases, it's probable in patients with rectal cancer, and we've heard both in esophageal, head and neck, pancreatic possibly, and lung. Very, very important principle. This provides, however, difficulties for the surgeon because when faced in a situation where a tumour has been downsized so that it can be removed, there are two issues. How does a surgeon know what to remove? Does one only remove what one can see at the repeat X-ray, or should one be removing the area that was present at the time prior to the neoadjuvant therapy? Very, very important issue which has got to be dealt with. And so these are going to be problems which we're going to have to face. But the third issue, again, which has come through very, very strong at our previous meeting, and again is part and parcel of this multidisciplinary approach, is the whole question of training, volume, and specialisation as far as surgeons are concerned. Whether or not the outcome of the outcome measures in any way are related to the volume of cases that an individual surgeon is carrying out, whether it's related to specialisation or whether there are other factors, because these are huge political issues which will affect governments and departments of health in terms of costing, whether or not it is a better and more viable situation to concentrate and specific specialisations into large centres. So those are sort of issues which we debated last week in terms of the surgical approach to solid tumours, but key to all this and sort of the infrastructure to all these issues are quite clearly this multidisciplinary approach, not to treat patients who have a solid tumour in isolation, either as a surgeon, a medical oncologist or radiotherapist. Individually we can't provide the best treatment, the optimum treatment, only in combination and recognising each other's different therapeutic modalities will we achieve optimum results.